Greetings of the day, folks. Today we are going to discuss about the uh, hepatorenal syndrome, pathophysiology, and also clinical features. The proposed pathophysiology is given in this algorithm. So, in this algorithm, you can see that in patients with cirrhosis and portal hypertension, because of inflammation, bacterial translocation, and also vasoactive mediators, like in nitric oxide, etc. There will be splanchnic and also peripheral vasodilation, because of which there will be decreased effective circulatory volume and decreased blood pressure, and because of tachycardia, and also there will be cardiac output increase, and also the sodium retention will be there because of rash and sympathetic nervous system activity, and also there will be increased ADH. So the decrease and after because of diarrhea, diuretics, bleeding, a large volume paroxysm, SBP, and hepatic dysfunction, there might be further volume loss already on a patient with a decreased volume, and there will be sodium retention because of renin-angiotensin aldosterone axis, and also because of which there will be ascites and hyponatremia because of third spacing sequestration, and there will be renal vasoconstriction and a reduction in GFR. And because of nephrotoxic drugs like ACE inhibitors and ARBs and NSAIDs, there will be exacerbation of this condition. This leads to decreased renal perfusion and also hepatorenal syndrome. Okay, so we will be discussing about the diagnosis and also clinical features. So in HRS is a functional disorder, right? So therefore laboratory and imaging studies alone are not sufficient, and a high index of suspicion is required. And majority of patients are asymptomatic, and patient might be having AKI, which must be ruled out. So AKI decreases GFR and also increases burn level, and may result in HE as the initial presentation. So the classification of the hepatorenal syndrome is given by the International Ascitic Lab Consensus Workshop in 2007, which includes firstly patients should be having cirrhosis with ascites, first one. Then second one is the serum creatinine level higher than 1.5 milligrams per deciliter, and should be lack of improvement in the serum um, creatinine to 1.5 milligrams per deciliter or less after at least 2 days of diuretic withdrawal or volume expansion with albumin 1 gram per kg body weight per day with a maximum of 100 grams per day. And there should be absence of shock and lack of current or recent nephrotoxic drugs, treatment with nephrotoxic drugs, lack of that, and absence of parenchymal kidney disease as indicated by proteinuria of more than 500 milligrams per day. And there should not be any microhematuria, which is more than 50 red blood cells per hyperfill or abnormal renal ultrasound findings. So several aspects of diagnosis of deserves emphasis. First, in patients with no prior evidence or history of renal impairment, diagnostic criteria for HRS include an increase in the serum creatinine by 50% and above to a level of higher than 1.5 milligrams per deciliter. Although this definition is standardized, a subset of patients with cirrhosis and end-stage liver disease have profound decrease in muscle mass and urea synthesis that may in turn result in reduced serum creatinine and burn levels, thereby potentially delaying the recognition of HRS. Second, many medications, most notably diuretics, lactose, angiotensin converting inverse, and ARBs, NSAIDs may influence the patient's intravascular volume status and renal perfusion and should be identified expeditiously and discontinued. Okay. HRS may develop in as many as 20% of affected patients, so of the SBP. So this must be looked after. And also, therefore, low threshold for evaluating a cirrhotic patient with ascites for presence of SBP is required. So we must be having HRS in mind in any patient with cirrhosis, and also okay. So this table goes by this. So cirrhosis with ascites, no serum creatinine more than 1.5 milligram per deciliter, no or insufficient improvement in the serum creatinine level 48 hours after the diuretic withdrawal and adequate volume expansion with IV albumin, absence of shock, no evidence of recent use of nephrotoxic drugs, and absence of intrinsic renal disease. So This is how we diagnose, and there is an initiative that is the wait a second, sorry for the inconvenience. So there is this initiative which is acute dialysis quality initiative group that has stratified AKI and renal dysfunction in cirrhotic patient grades of increasing severity. That is what this table suggests. Okay, so AKI, CKD, and acute and chronic. AKI is 50% increase in serum creatinine or zero point 0.3 milligrams per deciliter in rise in serum creatinine levels in less than 48 hours. Chronic kidney disease, glomerular filtration rate less than 60 ml per minute for more than 3 months. Acute and chronic disease, glomerular filtration rate for less than 60 ml per minute for more than 3 months, and 50% increase in the serum creatinine level from the baseline in 48 hours, or rise of zero point 0.3 milligrams per deciliter in serum creatinine level in less than 48 hours. The panel also proposed the changing nomenclature from hepatorenal syndrome to hepatorenal disorders to encompass all the patients with end-stage liver disease, cirrhosis, and concurrent kidney dysfunction. Urinary markers such as IL-18 and urinary neutrophil gelatinase associated lipocalin may be able to distinguish acute tubular necrosis from other etiologies of renal failure in cirrhosis, but their role in clinical practice is not defined. So, coming to the classification, HRS is classified into two types, type 1 and type 2. Type 1 is rapidly progressive, it is first in the class, right? So, it will be rapidly progressive. Uh, Typically, the serum creatinine levels doubles to a value higher than 2.5 milligrams per deciliter in a period of 2 weeks or less. Type 1 is often triggered by an inciting event that causes a rapid decline in hemodynamic parameters that maintain renal homeostasis in cirrhotic patients. The most common triggers include the severe bacterial infections. So, GI bleeding, surgical procedure, and acute liver injuries may also be a common cause of triggers. SBP, that is main bacterial infection that predisposes cirrhotics to develop HRS. The patients with higher levels of inflammatory response markers and severe circulatory depression prior to the onset of infection and adrenal insufficiency are most susceptible to development of HRS. Okay, so where there is a higher bacterial infection, severe circulatory depression, there might be, and also adrenal insufficiency, they are more susceptible to HRS. Type 2 HRS is more slowly progressive and is observed in patients with severe ascites, that is mainly diuretic resistant, and the median survival of approximately 6 months. Okay, so it is still slowly, but it is also having a poor prognosis, and the degree of arterial hypotension and circular dysfunction is less than that seen in with type 1 HRS. Okay, so type 1 HRS may develop in patients with type 2 HRS following a triggering event, and many patients with cirrhosis and portal hypertension also have underlying chronic kidney disease, which complicates the recognition of HRS even in the presence of underlying pathophysiological mechanisms that favor development of HRS. Okay, so whether these patients should be considered to have a unique form of HRS like type 3, or whether they should be treated as the same fashion similar to that for other patients with HRS have not been clearly defined. Whether the more sensitive rifle criteria classification of AKI will improve the diagnosis and therapy of kidney dysfunction and cirrhosis and alter the are areas of ongoing investigation. So thank you for the watching of this video.